Good morning, sir.
Morning.
Shall
Good morning,
shall we
Milind.
start?
Yeah, you can start here.
Okay, sir. So I'm Dr. Milind, third year resident in Department of Surgical Gastroenterology from Mahatma Gandhi College, Jaipur, sir. Sir, I'm presenting a case of a 54-year-old female who is a housewife by occupation, is a resident of Bharatpur, Rajasthan. Is complaints of abdominal pain since 4 years and vomiting since 1 week, sir.
Okay.
The pain is dull aching, located in epigastric and right hypochondrium. It's 4 years. It's insidious in onset. The intensity, sir, is mild to moderate. Initially, it was mild in nature, sir. However, there are bouts of moderate episodes of pain, which was relieved by oral analgesic medication. The pain is intermittent in nature, radiating to back. However, there is not associated change with meals or a change in posture, sir. She also complains of vomiting since 1 week. That is around 2 to 3 episodes of day, around 50 to 60 ml in amount, sir, non-bilious and non-projectile. There is associated complaints of loss of appetite present, sir. She has also a past history of laparoscopic cholecystectomy done in 2004 for symptomatic gallstone disease. However, there are no intra-op findings available. The biopsy report is also not available. But when asked to the patient and relatives, they said the surgery was uneventful and the post-op course was also uneventful. She also has previous admissions for similar complaints in 2021, where they had been admitted and she was diagnosed to have a biliary stricture and they were advised for ERC stenting. However, the patient did not undergo ERC at that time because of the COVID pandemic. In 2023, again, she developed vomiting and pain, which was severe in nature at that site, where she was again admitted at Army Hospital, where she was only advised conservative treatment, sir. Again, last week she underwent ERC stenting trial. However, there was failure for ERC at stenting in view of strictures. However, there is no history of fever with chills, no history of nausea or vomiting currently after admission, sir, or abdominal distension. No history of jaundice or pruritus. No history of malignant hematomesis. There is no history of low-grade fever, malaise, joint pain. No history of shortness of breath or cough. She's a known case of hypothyroidism since 8 years, taking tablet thyroxine for 8 years, no other medical comorbidities. She also underwent total abdominal hysterectomy in 2012. However, again, no documents available. On questioning, they said it was a fibroid, hence they had to get uterus removed. She consumes vegetarian diet. She's a non-smoker and non-alcoholic. No, the sleep cycle and bowel habits are normal. There is no significant female history. So to summarize, sir, she's a 54-year-old female patient having dull aching epigastric and right hypochondric pain since 4 years, associated with non-bilious vomiting for 1 week and associated loss of appetite, and underwent laparoscopic cholecystectomy for symptomatic gallstone disease in 2004 as a diagnosed case of biliary stricture from outside, sir.
Just forget the history of benign biliary stricture for the time being.
Yes,
And then patient underwent laparoscopic cholecystectomy 2004, and
yes, sir.
he is now symptomatic after 20 years. So, are
Yes.
you like correlating these two findings?
No, sir. At present, just on the basis of history, sir, I would keep it in mind, but it not should be in the initial provisional diagnosis, sir. At present, she has come with us with dull aching, epigastric, and hypochondric pain. So I would want to evaluate the patient further. I would also think of a penny, and the pain is also relating to back, sir. So I will want to rule out pancreatitis in this patient, sir, considering it's a long duration of history. So chronic pancreatitis is a provisional diagnosis that would come to my mind, sir. Initially, I would also want to rule out the any liver pathology or any SOL which may cause this kind of a picture. A patient is also complaining of any vomiting since 1 week, sir. That is 2 to 3 episodes, sir. Not just on project.
After that, she became impatient. Otherwise, I would have exposed SMV.
Mute.
But I wanted to take off blood gastric and short gastrics also and see that part. But she was not allowed. She was getting impatient. So I clamped.
Someone is talking.
Please mute iPhone.
Sir, I'm muted, sir. Yes. So at present, she's come with us with vomiting also, sir. So I would also want to rule out any uh, ailments relating to stomach, sir.
Okay, so you are thinking in terms of liver pathology, luminal pathology of stomach, and pancreatic pathology at present based on the history of pain. Okay. Now, when you are taking a history, so it is better to avoid the like epigastric and hypochondriac word. So you can take pain in right upper abdomen or right upper quadrant for last 4 years. So
Okay, sir.
this is because this is patient language, the classical teaching.
Yes.
So and then the vomiting. So like how it symptoms got relieved. So you have not mentioned the relieving. Like in pain, you have mentioned the relieving or the aggravating. So like what are how her vomiting relieved over last
Her
1 week
vomiting,
persistent.
yes, she used to stay and kneel for all for half an hour to 1 hour, and then it would relieve itself. The vomiting, however, was not associated with any meal pattern, whether it was before meal or after meal. They could not.
Any association with the pain?
No, not associated
No,
with the
not
pain.
associated. Okay, so primary complaints are pain in the right upper abdomen and vomiting for last short
Vomiting.
history of vomiting for last.
So, on general examination, coming to general examinations, the
What
patient
is
is
the differential
conscious.
diagnosis after this history?
Sir, it seems to be more of a chronic pancreatitis to be my first provisional diagnosis in this patient, sir.
Okay. So if you are thinking in terms of chronic pancreatitis, so have you asked for any history of exocrine and endocrine insufficiency?
Yes, sir. There was no complaints of any steatorrhea at the
Go back to
time.
the previous slide.
Sir, I'm not mentioning.
Yes. So when you are keeping a differential diagnosis, your chronic pancreatitis is the first differential diagnosis. So it is always like you should rule out the negative. So the risk factors related to it and the complication related to your diagnosis. So that is important. Second diagnosis, you are thinking.
Second time diagnosis, sir, I'm thinking to be any SOL, sir, space occupied lesion, which may because it is a continuous slow growing complaints, sir. Progression of complaints is there, sir. So SOL in pancreas or any liver which may cause this kind of
Benign or malignant. So, like coming to the first diagnosis, chronic pancreatitis with vomiting, pain with vomiting. So, what else can happen? Like in last 1 week, that has started. The patient has developed vomiting in last 1 week. Patient was having pain for last 4 years.
Yes,
But he has developed vomiting. So, what can happen in a case of chronic pancreatitis when you?
sir, there may be any collection or pseudocyst formation.
Okay. Any other
Which
thing?
may cause compression symptoms. Uh, if case chronic pancreatitis with an inflammatory mass which may cause obstruction leading to these symptoms.
Gastric obstruction. Okay.
Yes.
A group pancreatitis can also present as pain with the gastric obstruction and vomiting. So you should also keep in mind the sequelae, what has happened in last 1 week because she was not having vomiting. So something has happened. Now coming to the liver pathology, like you are thinking in terms of liver benign or a malignant pathology in this case, primarily.
There is so there is only loss of appetite. However, there is no loss of weight. So malignancy, it more seems to be a benign pathology rather than a malignant pathology that comes to mind, sir. However, we cannot, sir, rule out malignancy because she is 50-year-old female. The age factor and symptoms since last 4 years, sir, which are progressive in nature, sir.
And have you asked for any history of awareness of a lump in your history?
Awareness
Awareness of a lump in the abdomen.
No, yes, sir. That's she did not have any.
So you need to mention this, I think, if you are not mentioned.
Yes, sir.
So
Okay.
awareness of a lump is very important because if suppose a liver SOL a large just compressing on the stomach, it can lead to early satiety, but initially patient will not have a weight loss as you are mentioning. Okay, so first is chronic SOL. Most likely you are thinking in terms of benign pathology, and third is
sir, third, considering the history of laparoscopic cholecystectomy done in 2004, and she has given history of stricture, sir. So,
but patient is not giving any history of jaundice. You have
yes, sir. No cholangitis, no.
you have any cholangitis or any low grade. So why are you thinking or any other pathology that can happen? patient underwent laparoscopic cholecystectomy, but still having pain in the right upper abdomen. What can happen?
So there may be during the procedure there may be inadvertent injury to any luminal structure at that time, which would have healed by scarring or
while at injury, patient uneventful postoperative course, patient has no history of jaundice in the last 20 years. Any other thing, retained cystic duct stone, retained stone. It can lead to, like, if there is a cystic duct stone retained, it could have compression over the CBD, low grade compression that could have causing only pain but not lead to jaundice. So that is pathology. Retained cystic duct stone, retained stump stone. That because 20 years back, maybe the surgeon have not clipped the cystic duct. So these things you should come in mind. Pain, long-standing pain can lead to all these symptoms. So this comes in your mind. So like benign pathology, you have mentioned chronic pancreatitis, retained cystic duct stone, retained gallbladder stone, kind of a maybe an grade 1 MIRZ type 1 that can lead to all these things. Okay, and then liver pathology, and then last is like your luminal pathology should also keep in mind because patient has developed vomiting. So you should not.
Vomiting, yes.
Okay. So with this differential diagnosis, we'll go ahead. Okay.
Yes, sir. Sir, coming to general examinations, the patient is conscious oriented, moderately built and nourished, ECOG status of 0, with BMI of 19.2 kg per meter square. She is vitally stable with pulse of 74, BP of 110/64. Saturation is normal, sir, around 19% on room air. Breath holding time is 22 seconds. However, there is no icterus, no pedal edema, or no pallor, sir.
Okay, what is the full form of ECOG, ECOG?
Eastern Cancer Cooperative Group, sir.
Slowly. Eastern
Cancer Cooperative Group, sir.
Eastern Cooperative Oncology Group.
Oncology.
Okay. Go ahead.
On abdominal examination, sir, inspection, the abdomen is flat, sir. Umbilicus is central. The standard port-side scars of laparoscopic cholecystectomy are noted, which are well healed. No visible upper abdominal lump. No peristalsis or pulsations. The hernial orifices are normal. No visible cuff pulse. Renal angles are normal. Spine is normal, sir. On palpation, sir, abdomen is soft. There is mild tenderness present in right hypochondrium. However, there is no palpable lump in epigastric region or in right hypochondrium region. No hepatosplenomegaly. Liver span is 12 cm in mid-clavicular line. There is no shift in dullness on palpation. On auscultation, the ball sounds are normal, sir. On per-rectal examination, perianal skin is normal. No sinuses, fistula, or hemorrhoids. Then anal tone is normal with adequate squeeze. There is brown color staining on the glove. However, there is no palpable mass or nodule that is present, sir.
Okay.
Per examination.
More or less, nothing is significant examination. One more thing, like when you are talking about hepatosplenomegaly, it is better to mention that spleen is not palpable because spleen has to become palpable when it is 3 times large. So better to use a word. There is no hepatomegaly and spleen is not palpable. Nothing significant in the general examination as well as abdominal examination.
Yes.
Okay, so what are the differential diagnoses you are keeping after this? Any change in the order?
No, sir. We're still considering the same we had kept before because we cannot identify or any localizing symptoms or we cannot identify any generalized symptoms on examination, sir. Okay. No findings, clinical findings on examination.
One thing in history, you have mentioned that patient told you that doctors has advised ERCP.
Yes, sir. Yes, sir.
It was ERCP or some endoscopic procedure was advised?
They knew the name ERC because, sir, considering since 2021 they had been advised ERC twice, sir. So on one occasion they had refused. On another occasion it was failed. They could not. The procedure could not be completed in view of stricture, sir.
So ERCP, like it includes cholangiopancreatography. So it was done for pancreatic purpose, planned for biliary purpose.
For biliary purpose, sir. They had.
They know that this is for biliary purpose, not for pancreatic purpose. Maybe some PD stenting was attempted. No, nothing like that.
No, sir. Only for biliary purpose that it's done because they had there are outside reports of ultrasound and MRCP and CT scan. So on the basis of that, they had been advised these procedures.
Okay. So go ahead. What now? Any change in the differential diagnosis after system examination?
No, we shall continue with the same, sir.
Continue. So what is your plan now? What would you like to have after this thing?
Sir, I would like to evaluate her further with the blood investigations, including CBC, renal function test, liver function test, and followed by a routine ultrasound in this patient, sir, which would just help us in going further, sir.
Sorry, come again. What you told? What do you want to do?
I want to do CBC, sir, renal function test.
Do you
and
want
liver
to
function.
see her old records before doing anything extra?
Yes, sir. I had asked for the
So
old
you
records.
have to mention that I want to review her old record first, like because patient is like last 2-3 years, ultrasound must have been done. You are telling the doctors advised some CT, and then based on or MRCP, based on that they have advised ERCP. So it is better to ask for the previous investigation before you order a new investigation. Okay.
Okay, sir.
And one more thing. Okay, let's go. I'll discuss it later on. Now, what do you want from the previous old records?
So I would want an whatever the ultrasound and CT and MRI
Ultrasound,
sheet.
yeah, ultrasound, show the ultrasound report, which was done. Okay, this ultrasound
There are
done.
4 actually. This was the first one.
Just go slowly. Just go back. Yes. So this was done in last year, 2023, February.
Yes, sir. Actually, sir, there are 3. This was the 5
Go from
ultrasound have been
the
done.
previous one. Yeah, hold on.
Yeah.
So what is
Yes.
the report in this ultrasound?
They mentioned multiple small intrahepatic biliary duct calculi with mild bilobar dilatations.
Okay, so but this is the only information.
Yes, sir.
So
Otherwise, rest of the ultrasound was normal, sir. The only positive finding from the ultrasound was this. The rest of the USG was normal.
So what is the impression based on this?
Sir, based on this, we understand there is a ducts because of biliary duct calculi, which has caused dilatation, causing this pain. However, their patient
But
does
this
not.
dilatation, they have not mentioned about the common hepatic duct. Okay.
Common hepatic duct, and they
So
have not mentioned about
what
CBC.
like what is the differential diagnosis based on this ultrasound report? Forget
Based
about
on this,
BBS. I'm telling you, don't think in terms of
Yes,
BBS now. Just think what it can be. There are multiple calculi in the intrahepatic biliary radicals, and IHBRD is present. So what it can be?
hepatolithiasis because
Hepatolithiasis.
of,
Okay, correct. Any other thing?
we have to find out the cause of hepatolithiasis, sir, because the most common cause of hepatolithiasis in India at present is autoimmune disorder and
Okay.
any biliary parasites that may have caused because of this cause stone formation in
Any
the
other pathology where there are calculi in the intrahepatic region as well as in the cystic on the common bile duct, still patient doesn't have jaundice.
primary sclerosing cholangitis,
Cholelithiasis. Oh, sorry. Cholelitical cyst. Cystolithiasis.
Yes,
If they have like type 4A, will have stones in the intrahepatic radicals in the CBD also, but patient doesn't have jaundice because of the large. So this could be one possibility because there are radicals are dilated with stones. So hepatolithiasis is the possibility. One, as you mentioned, some parasitic disorders can be there. Okay. So another next ultrasound also shows similar finding, hepatomegaly with multiple calculi. What else you would like to see in this report?
Sir, I would want my ultrasonologist to comment on the status of the liver, whether liver is normal or there is alteration in echo texture. I would want to know about the status of.
Okay.
I also want to know about the status of CBD, whether CBD is containing any.
Just you want to know what is the status of the CBD, whether he can trace the CBD till the lower end.
Right.
One thing. Second, what based on your differential diagnosis, you should also think.
I would also want to know the status of the pancreas, sir, whether the pancreas is normal, sir, or whether any changes of pancreatitis is present, whether there is any pancreatic duct stones that can be visualized by the patient. There is any collection in the surrounding structures, if there is any present there. I would also want to know the although we have kept malignancy to be in later lower down in a yes, not differential diagnosis, but I would also want to know about if there is any mass present, mass lesion that can be visualized, sir. I also want to know if there is regional lymphadenopathy or any distant lymphadenopathy or metastatic lesion that can be,
Next.
and if there is any ascites present in these patients.
Okay. Any other thing?
Yes, I think so.
Okay. One more thing, like though you have mentioned about the status of the liver along with any liver SOL that is present,
Yes.
that was in our differential diagnosis. So based on a differential diagnosis, you have to order your ultrasound and look for what are the things you need to see. So go to the next ultrasound. Okay, this is the recent one.
Yes.
So, okay. So this is choledocholithiasis. Okay.
Choledocholithiasis, they mentioned the stones in CBD.
That's what we were discussing. This could
Yes.
be a possibility. Sometimes cystolithiasis primarily will not present with jaundice in some cases. Only pain is the primary symptoms, and you can find raised alkaline phosphatase. Okay. With this ultrasound, what do you want to see, or what else investigation has been done in the past?
Sir, I would, although some blood reports are not available, so I would want to order a fresh set of blood reports, which would include my complete blood count, liver function test, and renal function test, along with serum amylase lipase, sir. I also would want to order for any tumor markers, including CA19-9, which may help in rule out any malignant.
Are you thinking any malignant cause at present before?
Sir, I have kept lower down because there may be, however,
before ordering, would you like to do something else to reach to a diagnosis?
I would like to get an MRCP.
Was the MRCP done in the past?
Yes, sir, it has been done.
So let's discuss that before we order a new one.
Okay, sir.
Do we have the images here? Okay.
Yes, sir. So just so as you can see in this MR, sir,
sorry to interrupt. Milind, previously blood investigation was done before admission?
Yes, sir, they were done, but the documents are not available, sir. She had 4 to 5 sets of blood investigation.
Important to review the old record first.
Yes, sir.
Important before ordering any new investigations.
Yes, sir.
Okay.
So, sir, as we can see, sir, there is a cutoff that can be seen here.
This is a recent MR or this is the previous MR?
This is a recent MR, sir.
So you have
outside
to
MR,
the MRCP image or thick slab MRCP image of the given patient. On if date is mentioned, see the date of the patient, confirm that this is the MRCP of this patient only.
Yes, okay,
this is important.
So this is a recently done MRCP on 24th of February 2024, sir, of the same patient, sir. So there is, as we can see, there is a cutoff that can be seen
slab
here.
MRCP image.
Okay.
Showing
a discontinuous. There is discontinuity in the common bile duct channel, sir, with which we can see here. However, there is we can also see there is signal void in the left hepatic duct, which may diagnose about hepatolithiasis, sir. The right hepatic duct seems to be normal, sir, with the possibility of right posterior sectoral duct, right anterior sectoral duct, and left hepatic duct being there. However, the confluence is formed. There is a loss of continuity just after the confluence. The rest of the CBD seems to be normal, sir.
So, like, don't you think the lower end of CBD is also dilated?
Sir,
not collapsed completely.
Right. As compared to, yes, sir, there is slight dilatation. Even the PD is normal, sir. There is no.
PD is normal. You can see PD size is okay, but
also okay.
If there is, suppose there is a complete obstruction or there is a discontinuity, you can also see sometimes discontinuity cannot be there. Sometimes the hypointensity because of some stone also. So you have to mention that it's a hypointense area. That could be because of some stone or because of discontinuity. So with proximal critical dilatation. Okay.
Okay.
What else you are seeing in this case? Yeah.
Cystic duct stumps
central IHBR as well as peripheral IHBRD.
Peripheral.
This is important.
Yes, sir. So
if when we were discussing about choledochal cyst type 4A, periphery dilatation will not happen. It is a central one. So this is the way to differentiate between the two. So, anything in the lower end of the CBD?
So
Nothing. So,
nothing, sir. I can.
based on your this image, what is your impression?
So based on this image, sir, I'm suspecting to be in stricture that is type E2, according to Strasbourg's Bismuth classification. That is because the hilum is formed and it is just less than 2 centimeter from the hilum, sir.
So, your patient doesn't have jaundice with this stricture. So, what is the possibility? What is happening?
Sir,
Okay, I have not seen the LFT. Can you show the LFT also?
yes. So these are the routine recent investigations. Sir, the SGPT, OTR, sir, 81 and 88, sir. Alphos is raised, that is 419. However, there bilirubin is.
So how will you explain this phenomena? Like patient as having normal bilirubin with a seems to be a cutoff just below the hilum.
So, sir, there is partial obstruction and not complete obstruction.
Okay. What else?
Okay, and there may be, sir, internal fistulization that has already occurred in this patient, which is diverting the bile, sir.
Okay. So what do you want to do now?
Sir, I would want to want to get a CT scan done, sir, in this patient, sir.
Why?
I would want to know because, sir, I want to know if there is any SOL present in this patient, sir, based on my differential diagnosis. I also want to know about the vascularity that is present, sir.
What was the age of the patient?
54, sir.
54-year-old who has underwent laparoscopic cholecystectomy 20 years back, now presenting with a kind of a pain in abdomen for last 4 years with vomiting, and now there is a sudden cutoff at the level of just below the confluence with raised ALP. Jaundice is not there. Any other possibility, like, would you like to see in this patient? Any differentials apart from a stricture, like biliary stricture, but any other etiology or leading to?
There may be a parasitic cause of a stricture
Like,
or any
how to differentiate between a benign stricture between a malignant stricture?
stricture. So,
Malignant biliary stricture. There are two pathologies: malignant biliary stricture and benign biliary stricture. So, how will you differentiate between these two?
so generally, the strictures of benign disease are generally they are smooth and tapering, whereas malignant strictures are generally irregular with sharp, uh, sharp tapering, sir, at the end, sir. Besides, there may be
What is sharp tapering? Sharp tapering कुछ नहीं होता. What is sharp tapering?
I mean, sir, I'm not getting the word, sir.
Okay. Any other thing based on the history? Like this seems to be a benign and this seems to be a malignant stricture.
Based on this, sir, there is no loss of weight in this patient. However, there is loss of appetite in this patient, sir. So this goes more in the favor of a benign disease, sir.
Any other thing?
Then, sir, the only factor that can be considered in the favor of malignancy is that gradual progressive symptoms that are present in this patient, which were initially relieved with, but they are not relieved on medications anymore, sir. However, there is no evidence of any jaundice or any palpable or lump or any history of any lump that has been given to the patient. So more favors a benign cause rather than a malignant.
But like in benign pathology, if it has happened, if you are saying that patient underwent laparoscopic chole and that could be the reason, it usually happens in an early period. Biliary stricture secondary to some surgical intervention happens early in the course, but the malignant causes happens late actually.
Later.
So this is fitting in with your history that 20 years back patient underwent the gallbladder removal. Now she has developed this kind of a pathology. So why not malignant etiology?
So, but sir, certain times, sir, sir, you are right, sir. Malignant, it takes more time to develop compared to benign, which generally develops in the early postoperative period or just within few years of the previous surgery, sir. But sir, there may be the common cause of stricture formation of after an uneventful lab cholecystectomy is generally a denudation of the CBD, which may hamper the blood supply of the actual blood supply that is supplying the CBD, or any inadvertent injury to any right hepatic artery at that time, sir. So maybe the collaterals would have formed initially at that time, which would have kept this going on, or even the stricture may have formed at that time, but because of internal fistulization, the patient has come to light after so many years, sir.
Ischemic injury has led to this kind of pathology along with the internal fistula. That is, the patient has not presented so early. But
Yes.
when the patient develops internal fistula, what happens to such kind of patients? What are the classical history they have? When there is a biliary drainage into the duodenum, what will happen?
So there will be it will cause duodenitis in this patient, sir.
The patient will have reflex cholangitis.
Cholangitis.
You will have intermittent episodes of low-grade fever, mild jaundice. This actually happens when there is an internal fistula. Because the fistula is small opening, it closes, there is a collection of secretions, and it like suddenly opens up. Patient develops some kind of pain, fever, and it relieves. So this happens when there is internal fistula. So this history is not there. So the other thing you mentioned, there is a partial continuity in the CBD. So that can fit in, but we need to see. Okay, so to rule out any vascular injury, to rule out any malignant cause, I would like to look for the CT scan. So CT scan.
Yes. CT, sir, we have only the report because it was done outside and it was done in 2020 at that time. We do not have any of the images of the present, sir. So the report, the positive findings were suggestive of narrowing is seen in common hepatic duct with mildly dilated bilateral IHBR and patent biliary confluence, suggestive of biliary.
So one thing, it is not bilateral, it is bilobar.
Yes.
This is wrong. This
Wrong
what
there.
is written in the report. It is bilobar IHBRD.
Yes.
Lobar is not bilateral, it is bilobar. Okay.
No enhancing wall thickening and sizable mass lesion is common. Ciliaco-mesenteric trunk is seen, which is normal, sir.
So what else you want to see in this report? Or CT
So
scan? Do you have any imaging?
No, sir. The only image we have is of an MRI. Previously, in 2021, also there was an MRI done, and CT was also done in 2021. Again, they mentioned the same. It is a post-cholecystectomy status, metallic clip seen in GB fossa, indenting the proximal CBD, causing dilatation of CBD and mild central and peripheral bilobar IHBA dilatation with no obvious mass lesions seen. So this was the second CT that was done.
Now, what else you want to see in this report, or what else you want to see? Do you have any imaging pertaining to this case?
No, sir. That the only imaging we had was MR.
So what do you want to see? Like suppose a CT. I'll give you a CT video. So what you will see?
Sir, I would start. I would want to see initially the status of the liver, formation of the ducts, ductal confluence.
Before that, like go from arterial phase, portovenous phase, and delayed phase, or non-enhancing phase, non-contrast, arterial and portovenous. This is the way you see the CT scan.
Yes.
So you have to see this is the CT scan done on this case, and the non-contrast image showing. Now start.
Non-contrast image showing, sir. I would a normal liver, sir. No. If there is any evidence of any stones or any calcification that can be seen anywhere in the
liver, you comment upon any calcification that is present or any clips present. So where are you looking for calcification? Where are you looking for clips?
Sir, I want to look at the clips in the gallbladder bed, GB fossa. That is where I am looking. For calcification, I am looking at in any intrahepatic ducts or in the CBD or a pancreatic duct, whether any stones are present.
Okay, next arterial phase.
In arterial phase, I want to know about the vascularity. If there is a patency of the trunk, that is common hepatic trunk that is present, right hepatic and left hepatic artery can be visualized. I would also want to see the origin of the hepatic arteries.
I will trace the right hepatic artery in its course from the proper hepatic artery. Where is the division? Whether it is a replaced right hepatic artery or an accessory right hepatic artery, and I will trace its course, because I was like
I was,
ischemic injury, because this
yes,
has
yes,
happened
yes.
very late. So this is my intent to look for. So okay, then
Then, sir, I would want to see any mass enhancing mass lesion if it is any present arterial enhancing mass lesion that will be present uh, in the head of pancreas or in the liver any as well if it is
but
present,
that
sir.
we are not like this is we are not thinking in those terms.
Those,
So
yes,
unlikely. So okay, next.
yes. Then, sir, CT. Otherwise, any lymph nodes which are present, which are enlarged in
You
the
will like
surrounding organ.
arterial phase is for looking for any arterial changes. Now go to portal venous phase. This is the way you see the CT scan. Okay,
Yes, and portal venous phase, I want to like know the patency of the portal vein. If there is any thrombus, it is present. I want to trace the course of portal vein also.
done.
Normal formation of portal vein from splenic vein and supreme
Now
mesenteric vein,
liver.
sir. And in the liver, sir, I want to know the bifurcation of the portal vein, whether idiopathic
Done.
right portal
Liver
vein.
done. Next, any other thing in the liver?
If the liver is properly enhancing in the portal venous phase, I would want to know about ecotexture of the liver and any other mass lesion. That's it. In the portal venous phase. Any metastatic deposit that can be seen in the liver, I would want to know.
Okay, so you like your intent is to rule out any malignant causes.
Malignancy,
You
yes.
will see is there any what are the status of the IHBR, any cholangular abscess, any liver SOL. Then I will see the trace the biliary continuity whether it is maintained or not. Is there any enhancing lesion in the at the level of the hilum just where the structure is, and any lymph nodes present there or not. Okay, any free fluid present or any deposit elsewhere.
Like,
Okay, so this is the way from liver, you come to the bile duct and then lymph nodes like T, N, and then M. Okay, so would you like to do an MR in this case or a CT in this case
no,
forehand?
sir, I prefer an MR because I would want to know exact anatomy
So, like
of
you will
the
do MR as well as CT,
CT. Yeah. No, I'll do
or
both, sir. I'll
you
do,
can do an MR angiography with MRCP.
sir, yes, MR angiography with MRCP can be done, but sir, CT is better for characterization of any. Although we are not looking at the malignancy per se, but CT is better at characterization the malignancy as well as the rule out any calcifications that can be seen compared better to MRI, sir.
But like nowadays, MRI is less standard of investigation for liver lesions. So, but if center is available, if the at center is available and radiologist or you are confident, you can go with MRI, see MRI with MR angio with MRCP that will can give you the exact information about the arterial and arterial changes, arterial vascular changes, if any, as well as lesions present there or not. So, CT done, MRCP you have done. So, what is your plan?
Sir, I would want an ERCP ERC to be done. I would want to know if if I could pass the stent through the stricture, if it is possible to pass the stent. Uh, if the distance between the ends is low, then we can try putting a stent through
What
the
kind of stent you are planning?
a plastic stent initially because we are planning for a surgical procedure in this patient, sir.
If you are planning a surgical procedure, why you want to put a stent and infect the area? Or like in like nowadays, people are not putting plastic stents. For your knowledge, it is like they are putting covered metal stent that has a better patency, better like luminal competency. Lumen is not compromised early. So if you talk to the endoscopist, they will prefer to put a short metal stent, covered metal stent for these kind of cases. But what is the literature says? What is the success rate of stenting versus surgical procedure?
Sir, in, surgical procedure is far better compared to stenting. That is what you mentioned.
There are plethora of literature available, and your gastroenterologist friend will say that I can manage this kind of a stricture with repeated stenting.
But repeated stenting is cumbersome for the patient, sir. Multiple procedures had to be done in
But
this patient, sir.
patient saying I can uh, I'll avoid a surgical scar. So how will you counsel your patient? Endoscopic
Sir, I would
stenting versus surgical management. Now this is the question.
surgical management should be ruined by petechojejunostomy in this patient,
No,
sir.
no, you have to defend. Okay.
Okay, sir, yes.
Go ahead. Like one school of thought is saying endoscopic stenting, one is saying surgical management. So how will you convince your patient?
Sir, I'll convince the patient in a way that the surgical procedure is better because
So
there is
at an MCH level, you should tell in terms of like you should quote some articles, you should quote percentages because this is required. Now you have crossed the history and examination. Now that examiner is looking for your knowledge. So you should ask in terms of that what is the percentage of stent patency, what is the percentage of success rate in your surgical management. So this is the way you show that you have a knowledge, you have read. Now this comes your knowledge. Now go ahead.
Sir, I'm not aware of the exact percentages or any
So this you
articles.
should learn. In the case, you should know what is the success rate of endoscopic stenting, what is the success rate of surgical intervention, what is the mortality in surgical intervention, what is the morbidity in endoscopic management. So that is why you counsel your patient that why you are going for a surgical management, why not endoscopic management.
Okay.
Okay. So, like if suppose they are not able to, because as you mentioned in history, they tried for ERCP, but
they could not
able to pass the guide wire.
Yes.
So this is a simple scenario. You will tell the patient that guide wire is not possible. There is no option left. So surgical management is required. So what is surgical management you are looking in this patient?
Sir, I'm planning to do
in pre-operative period.
So what's a pre-operative?
Anything else you have like left in pre-operative period, or you will go with surgical management straight away?
Sir, I'll patient. There is no investigation. I would want to get just to be on a safer side. I want to get a CEA levels done. Just serum CA99 levels done, just to rule out any. If you are looking at any
possible. MR didn't show anything.
Yes.
You want to do? What is the sensitivity? Even if CA suppose is raised, so what your CA99 is raised, what will you do next?
So then
19-9 is raised. So what is
sir, if
implication?
If CA, because sir, if CA99 is, although if CA99 is even raised, then our however, it would be insignificant considering that we want to patient is not in obstruction as such. So we straight away proceed for surgery. So we go for Roux-en-Y hepaticogenestomy in this patient.
CA19-9 is raised. Suppose patient without any jaundice, so you will review your imaging again that whether I have missed something or not. There might be a possibility. So don't, if an investigation is present, you need to revisit whether I have missed or not. You to discuss in a gastro-radio meet. And sometimes if it is not, then you can also go for an EUS to look for is there any local or not. So if it is positive, you have to go for it. Okay. Next, then what? Next, what else?
Sir, the patient. I would just prepare the patient for the surgery then, sir.
What surgery you are planning for here?
Open Roux-en-Y hepaticogenestomy. That is what I'm planning, sir, in this patient.
Okay. So, okay, just so what are the different types of like what are the classification of biliary injury? Just for the
yes, sir. As per Bismuth classification, type 1 is a stricture greater than 2 centimeters.
I have asked for the biliary injury.
Injury, okay, Strasbourg classification, sir.
Yeah.
For biliary injury.
Listen to the question. Biliary injury or biliary stricture, two different things, two different classifications. Okay.
Okay. So type 1 biliary type 1 biliary injury, type A biliary injuries in Strasbourg classification. It includes injury to leak from the cystic duct or accessory duct. Type B is occlusion of right posterior sectoral duct. Type C is a leak from the right posterior sectoral duct, sir. Type D is
what is B and what is C?
Type B is leak occlusion of right posterior sectoral duct, sir.
Right accessory duct. Okay.
And type C is the leak from that side without clipping. We have not clipped and it is leak from that side.
Divided. Okay.
Type D is lateral CBD injury. And type E involves stricture formation from E1 to E5 that incorporates the bismuth.
E is like complete cutoff basically.
Complete cutoff.
That will convert into stricture later on. Okay. So
and E1 is greater than 2 centimeter. E2 is less than 2 centimeter from the hilum. E3 is at the confluence. E4 is ductal interhepatic ductal involvement, and E5 is the reduction involvement.
So like in this case, because it's a delayed stricture which has formed, and you are anticipating arterial injury in this case, so what will you do? Anything will you do in such case?
Uh, I would try to go. I would try to make my anastomosis as proximal as possible. It at higher up as possible. So
What higher up, what will you do? Like you are into that.
I will do a ductotomy, which will be extending into the left hepatic duct, and try to do the anastomosis as proximal as possible.
You will open the left hepatic duct, okay, right? So what are the change? What are the prerequisite of a good hepatogenostomy?
Sir, the stoma size should be of adequate size. It should be around 2 centimeters in size, sir, minimum. And sir, because hepatolysis is already present in this patient, I want to flush out the hepatic duct stones by the catheter, sir. The type of anastomosis that will be done would be mucosa to mucosa in interrupted manner, sir.
That is the requisite of a good anastomosis. I'm talking about not anastomosis. Just how will you before doing anastomosis? What all things fit in that happened? So you mentioned that I will extend my what is Hep coronary approach? Okay, I am interrupting you.
So Hep coronary approach is to mobilize the duct by lowering the hilar plate, sir. So lower the hilar plate, I would have adequate mobilization so that my anastomosis which I make is not under tension or any.
Open the horizontal part of the left duct. A wide anastomosis. You have mentioned one is you will load on the hilar plate. You will extend your incision on the left duct. You will make a wide opening of around 2 centimeters. Anything you will remove all the stones. You will flush out the stones, and any other thing you will do to check what any other thing that is left.
Sir,
any other thing that is left.
We can do, sir.
All the biliary channels are draining. That you are not missing on anything. Like all the biliary channels are draining into that opening.
Do the cholangiogram, sir.
A cholangiogram you can do, or you can do a cholecystoscopy also.
Sure.
So see that all the stones have been cleared. You have entered into the left duct. You have entered into the right anterior and the right posterior sectoral duct. So the prerequisite is that all the biliary duct should drain into your anastomosis. Okay. So this is one thing that you should ensure. And will you try for any vascular reconstruction if it is injured?
Sir, at this point of time, considering so much of time that has been passed, if it would have been an acute condition, then acute scenario, then we would have considered reconstruction. But in this scenario,
not required because already.
Yes, sir.
So coming to the next part, what are the ideal hepatogenostomy? What all things you will do while doing the anastomosis?
Sir, around 25 to 30 centimeters from the EJ, we will take the jejunum, sir. It should not be under any tension, sir. The suturing technique, it should be mucosa to mucosa technique, sir, with the interrupted suturing technique with PDS sutures.
Absorbable sutures, basically.
PDS 4 or 5 sutures.
And what are the causes of mortality when you are operating BBS, a case of BBS?
Cause of mortality, sir, mostly, sir.
What are the causes of morbidity or mortality? Well, in a way, what I'm asking is what precaution you should take when you are opening up such kind of an abdomen.
Sir.
And in this particular case, this is likely you will find intraoperatively.
Sir, I would want to drain any collections if it is present, sir. First of
any
all.
collections, fine. Any other thing?
I would want to. So there will be scarring and inflammation, fibrosis that would be present in the GB4 areas. I would be avoid inadvertent injury to any major vascular structures.
Vascular structure as well as duodenum, because in this case you will find an internal fistula. So while mobilization, sometimes there is a small opening in the duodenum, it opens up. So the bowel injury, because there is so much adhesions, can be a cause of morbidity and mortality in a case of BBS. Okay, now so you should should mobilize your bowel, omentum, hepatic flexure very carefully in this case, in these cases. Okay.
Vaibhav sir,
So, doctor, Anand, sorry, Anand, batao.
in this case, he mentioned to forget one thing. As the patient had a biliary stricture, as he knows, he should have mentioned the color of the stool she was passing.
Yeah, that is required. That will help us to know whether the patient having cholestatic features or not.
Yes,
Okay.
yes.
So, color of urine and color of clay colored stool will help you out that.
And why this patient is not having jaundice and raised OTPT in spite of last 20 years of stricture? Don't know. What do you think regarding this?
Some internal fistula or like small continuity must have been there. This is the
Okay.
only possible thing that we could.
Now it's
Very not a classical presentation,
mhm.
but you will definitely in such cases there is an internal fistula that is present.
Yes.
That is why it is. But the other thing is that patient is still having IHBR that is disproportionate to the level of bilirubin. I think you should repeat the bilirubin again.
It was done at our institute again. So normal.
Again, normal.
Also,
Hello, I think so. You should read some theory also, because
Yes,
if you cross your history and examination, then after their history and examination skills, there comes their knowledge. So at that point, and like keep the imaging with you. Like better to get the imaging done at your center, so that you
Yes.
know before you go in. Don't based on your report, don't go in. So it is always better to see the imaging yourself and then do the surgery. It is always better. Don't rely on the reports.
Yes, sir. Now it's 10 o'clock, sir.
Okay, we're
Thank
done.
you.
Oh my God, thank you so much.
Thank you for accepting our request.
No,
Thank you.
thank you so much. Chalo, Anand. Okay, take care.